Regarding shoulder examination, I will check for the age, occupation, dominance, and premorbid functions, nature of the pain, especially ask about the neck pain and radiculopathy. Pain and stiffness, think about frozen shoulder, avian, and rotator cuff arthropathy. Weakness, think about muscular or neurological plexus injury. Young, think about instability, would like to know, does it feel unstable, previous traumatic dislocations, level of sports, number of dislocation, age of first dislocation, and type of sports, neurological symptoms, functional assessment, and general outline of history as previously discussed. When I examine the patient, they should be sequential, look, feel, move. I will expose the whole area, start from the front, check the AC joint, sternoclavicular joint and clavicle. On the side, checking for the vestige of deltoid, going to the back to the scapular position, supraspinatus, infraspinatus, and any scar for check for tenderness, start from bony, start from the anterior aspect, go towards the sternoclavicular joint, go laterally over the bone, go reach the acromion, go posterior, supraspinous, spinous, prospinous, spine of scapula, palpate the supraspinatus, infraspinatus region, check for the bicep tendon, move and check for tendons in bicep tendinitis, feel subacromial region, and then start moving, screen cervical spine, and then look from behind while doing forward flexion, abduction, and observe the scapular dyskinesis. If there is winging of scapula, do a press test over a wall, check for abduction, high arc pain at AC joint. Last 30 degree of abduction is painful. Painful arc is 60 to 120 degree in case of impingement. Observe scapulothoracic rhythm, and if inability to initiate shoulder abduction might indicate supraspinatus tear or weakness. Palpable click may be long ahead of bicep subluxation. External rotate the elbow and internal rotation. While doing external rotation, ask for check for the range of motion. If there is active extension is restricted, indicates supraspinatus weakness or tear of supraspinatus of suprascapular nerve problem. Check for active and passive extension. If both are not possible, this means either osteoarthritis or frozen shoulder or locked posterior dislocation. If there is no active or passive movements in glenohumeral joint, this may indicate arthrodesis as well. If there is increased passive external rotation, this means there can be a subscapular tear, so there will be increased external rotation passively. Check for internal rotation. Then you can show adduction and extension. Regarding the tests, special tests, first of all, do the Beighton score. Check for cross-body adduction or scarf test to check for AC joint pain. Then you do O'Brien test, is basically arm adducted and forward elevation with thumb down. Resist elevation causes AC joint pain. It can be positive in slap tear as well. Reduced pain when the thumb points upward. Then you can check for the near side. One hand on the scapula and other arm elevates the shoulder in the plane of scapula and internal rotates. Positive if passive forward flexion more than 90 degree causes pain. Near test is reduction of the pain when you give local anesthesia. Hawken test, shoulder is abducted to 90 degrees and elbow flexed to 90 degrees. Gentle interrotation causes subacromial impingement. Pain with flex adduction and active interrotation is subcoracoid impingement. When it is rotator cuff problem, examine power and lag as well. Job empty can test is for supraspinatus. Resist elevation in the plane of scapula with arm internal rotated, thumb down, and check with the patient trying to actively elevate and force it downwards. If there is a pain or weakness, weakness means pain, weakness means tear, and pain means tendinitis or bursitis. Drop arm sign, passively elevate the arm in the scapular plane to 90 degree. Ask the patient to slowly lower the arm. Positive when patient weakness or pain and the arm drops drops quickly. External rotation against resistance in adduction is for infraspinatus. Interrotation against resistance in 9-degree abduction is for teres minor. Hornblower test, shoulder placed in 90 degree of abduction and 9 degree of external rotation. Ask the patient to external rotate the arm and try to resist it. If the arm drops in internal rotation, teres minor weakness. This is called Hornblower test. Gabber lift off, ask patient to put hand behind their back. Initially ask to lift hand off the back. If they can do it, then do it from with resistance. This indicates subscapularis function. Belly press test is basically also called Napoleon test. Bring arm elbow forward, passively internal rotation, and lag sign. It might be positive in massive tear. Now for instability, sulcus test, sit behind the sitting, ask the patient to be sitting, pull down in external rotation, a gap will appear in the acromion, you can measure it. This shows inferior capsular laxity, should be compared on the opposite side. Then anterior posterior drawer side test, sit, abduct shoulder, stabilize scapula, move humeral head in assessment of shoulder instability. Apprehension test, in a flexed, abducted, and external rotated shoulder, use the thumb. Anterior directed force to the humeral head will cause apprehension. Patient will feel that the shoulder is going out. Job relocation test, feel relief when the humeral head is pushed backward following above test. Posterior apprehension or jerk test, flex shoulder to 9 degree and internal rotation and apply posterior force through the long axis of humerus. Kim test, sublux with posterior applied force as arm is dynamically adducted by the examiner. For biceps, there is Yergesen test and speed test. Yergesen test, elbow flex 9 degree with forearm pronated. Patient supinates forearm against resistance. Patient feels pain in bicipital groove. This may be bicep tendon pathology. Speed test, patient arm lifted on 9 degree forward with elbow extended. Press arm down against resistance. Pain in the anterior deltoid region shows bicep tendinitis or bicep pathology. Check for neurological examination. Arthrodesis may be due to neurological injury itself.